Uh, Presenting Mr. X, she's a 41-year-old housewife from West Bengal. She presented with complaints of recurrent abdominal pain for the past 3 months. Her first episode was in May of 2023. She had an upper abdominal pain, epigastric, which is associated with back pain. It was very severe with vomiting, and she required admission for 7 days. And she did not require oxygen, she did not require any dialysis support, or she was managed conservatively and discharged in a stable condition. Post that, she had a similar episode after 1 month, and in between, there was no fever, no loss of weight, loss of hair, jaundice, no altered sensorium, no alternative medicine intake. She's prior comorbidities of diabetes for the past 6 years, on insulin for the past 1 year. On examination, she was conscious, she was on time, place, in person. Pulse was 98 regular, all pulses were palpable. General examination, oral cavity was showing poor oral hygiene, otherwise systemically. Respiratory system, trachea was central, normal vascular breath zones. Cardiovascular was normal findings. Abdomen was soft and non-tender. Neurologically, no deficits were noted. She had come with a diagnosis. She had an outside CT report showing acute interstitial pancreatitis. So she was in OPD itself. She was evaluated like what are the causes for the pancreatitis. In the common prevalence, biliary alcohol related, hypertriglyceridemia, hypercalcemia, drugs of pregnancy, idiopathic cause. Our patient evaluation, hemoglobin was 11, platelets were 3 lakh, total counts were normal. LFT, there was no raise in bilirubin or alk-phos. Electrolytes were normal, renal functions were normal. For diabetic workup, urine glucose was 3 plus with protein of 1 plus. UPC was 0.2 with 100 milligrams of protein in 24 hours. Her amylase lipase at this point of time was not elevated. Her calcium was also 9.1. Her lipid profile, however, the triglycerides were known to be 4,560 with total cholesterol of 710. So the repeat CT right now, which was done, which is showing, showing a bulky pancreas with peripancreatic fat stranding, which they were suggesting a probable features of active pancreatitis. But clinically, she didn't have any symptoms, and biochemically, she didn't have elevated enzymes. And there was no complications of pancreatitis were noted in this current CT. So I would like to talk specifically on the hypertriglyceride associated pancreatitis management. So the pancreatitis management is in itself is a separate topic altogether. And for hypertriglyceridemia, the target is to get the triglycerides to below less than 500. So the known association of triglycerides being more than 1,000 is a risk factor individually for developing pancreatitis. So what are the available options so far? We have use of IV insulin, and additionally, we can use plasma exchange, and then lifestyle changes, and then pharmacological measures. So general measures for all patients with if the underlying risk factors predispose further for worsening triglycerides. So with the diabetic uncontrolled, their triglycerides tend to be higher. So we need to get the glycemic control, lifestyle changes. So from a sedentary lifestyle, they can be encouraged, and hypertension, blood control. Diet is advised to be fat-free, even less than 5% of fat. Smoking cessation, avoid alcohol, weight loss of 5 to 10% in 6 months. Using pharmacological measures, LDL reduction with statins, and physical activity. So the approach for hypertriglycemic pancreatitis is to assess the severity of the pancreatitis with specific note on special evidence to suggest there's some worse prognostication, presence of hypocalcemia, lactic acidosis. The signs of worsening inflammation is in either form of temperature, heart rate, respiratory rate, or WBC count. And presence of other organ dysfunction. If any of these are there, it's indicated to start with the plasma exchange, and to target the and to repeat cycles every once in 2-3 days till levels of less than 500. And along with this, they have to go through the other dietary measures and general pharmacological measures till levels are less. In case they are not fit, either because of an organ dysfunction or they don't have a center access to the plasma exchange, they can start with IV regular infusion with monitoring of glucose, and then monitoring of triglycerides on a daily basis. If the patient does not have any of these worse factors, and if they're just noted to be hyperglycemic, you can directly start them on insulin with monitoring for the triglycerides and the glucose. If they're not hypoglycemic, we can if they don't have any worse factors and they're non-hypoglycemic, we can just start with dietary restriction, lifestyle modification, and pharmacological measures. So, what is plasma exchange here? How does it help? So, the triglycerides, the a single. It's been noted that a single session of plasma exchange has been reduced the triglycerides even by 50%. So, a person with 4,000 even come down to 2,000 in one session. The current suggestions for using the plasma exchange is for each to bring the triglycerides to less than 1,000, and each measure to be measured after each cycle. So the current evidence to suggest these things is based on only on observational and case reports and retrospective studies. So one of the retrospective studies has shown that they've come to a conclusion that the plasma exchange does not help in uncomplicated cases. That's why the plasma exchange is recommended in the patient with any of the worse worrisome factors. So the study, the population they've taken is retrospectively the people who visited the hospital with 67 pancreatic patients with noted triglycerides of more than 4,000, and they've received either medical or they've received medically plus therapeutic plasma exchange. They've excluded multi-organ people here itself, so that's why they came to a conclusion that in the absence of multi-organ dysfunction, or there is no mortality benefit or the length of the stay hospital benefit. So the second option we had was IV insulin. So how do we use it and how does it help? Insulin helps with the adipocyte lipase. It inhibits the adipocyte lipase. So that's one way of reducing the triglyceride entry and fatty acids into the blood circulation. So how do we start it and how much do we target it at? Target glucose should be targeted at maintained about 150 to 200 to avoid hypoglycemias. And we can start the infusion at 0.1 to 0.3 units per kg per hour with either as a fixed dose of insulin infusion with maintaining the sugars by either using 5% or 10% extras, and the levels go down below 200. So far, noted studies were suggesting it's better to use the IV infusion rather than a bolus or a subcutaneous intermittent boluses. So our patient, what he received, she didn't have active pancreatitis at this point of time. So we started on an insulin infusion. She required like highest of 10 units per hour with 10% extras to avoid hypoglycemias. And she received pharmacological therapy with fenofibrates, high dose ezetimibe, and rosuvastatin and omega fatty acids. So look at her starting. She had a triglycerides of 4,500, which till 600 we continued the insulin infusion, and after that stopped. We noted that the drugs, the fenofibrates increase the lipids. So that's why the LDL levels have gone up in this person.
Sir, one question for you. See, why did you do the CT scan? I mean, what are the indications for doing a CT scan?
And for the late complications of pancreatitis.
No, so why did you do CT scan for this patient? What was the indication for the CT scan?
She didn't have pain or swelling.
Yeah, so I mean, like even when we see a patient with acute pancreatitis, the indication to do a CT scan is only if the diagnosis is in doubt, and that's the only indication, or else to pick up complications, which is much later on, maybe around 10 to 14 days or in the third week of illness. But doing a CT scan in this stage, we know the history. I think it come with a pancreatitis episode, and you were just investigating for the etiology of the pancreatitis. That was, I felt, was a little not needed. And the second thing is, in this patient who did not have an active pancreatitis, was there a role for that IV insulin therapy? I mean, generally you would just give fenofibrates. So
she had so far 2 episodes. There is no recommended thing, but we did give.
I mean, as far as my understanding is, for when here you're trying to control the triglycerides to prevent a recurrence. In my understanding, it would be just medical therapy, and you would consider the plasma exchange and the IV insulin therapy when the patient had an acute severe pancreatitis as per the Atlanta classification with organ dysfunction. So what the points that you mentioned earlier about organ dysfunction, lactates going up, that is if a patient has a severe acute pancreatitis and if it is lasting more than 48 hours, you would consider therapy with plasma exchange. Any?
Was she investigated for the cause of that severe hepatitis?
We've screened the son. We've not done further evaluation in her yet. She was on estrogen OCP. She was on, and she's uncontrolled diabetic. HB1C was not. She's also hypothyroid. TSH was this time identified to be 9.
What is TSH?
9.
Second, why did she need the rosuvastatin at 40 milligrams per day? Her LDL was always normal. And she have any atherosclerotic cardiovascular disease?
History-wise, no.
Nothing.
So I think as Sir is saying, no, a lot of the medications that we start, we need to think about what is the indication, what are the potential side effects which can happen to the patient. So we should have a clear indication for starting the medications and the treatment for the patients.
How bad was the glycemic control?
So sugars were starting index was around 380.
HbA1c?
HbA1c is 9.9.
First thing should be a daily
Sugar.
very good sugar control.
Yes.
So, serum lipid.
Yes, sir. I've not seen the same, but in the first sample, there was mention of like.
Yeah, sometimes the thing is it looks white. It's good to actually see these and take photographs of that because that's how you learn. You're just keeping the sample and even in the ward for some time, you'll be able to see what the serum looks like.
For patients on ART, evidence-based treatment, recurrent pancreatitis, like serum. Once we change the ART, it's
Thank you.